Have you treated Anserine bursitis in the medial knee, but seen no improvement? Or had patients say their pain got worse? If so, don't miss this chance to learn what might have been missed. Stay tuned. If I were to highlight the most significant misconceptions, or errors in judgment I have encountered in managing chronic medial knee pain, pes anserinus bursitis would stand out as the most misguided diagnoses. This time, I will focus specifically on medial knee pain. Many clinicians, including myself, have traditionally misattributed such pain to pes anserinus bursitis and chronic coronary ligament tears, considering these to be the primary and most frequent causes of atraumatic medial knee pain. For 15 years, I based my diagnoses solely on physical examinations, X-rays, and ultrasound imaging. I learned from the experts and have taught this misconception to the learners for a long time. Still, many ultrasound experts are teaching to beginners. However, with more extensive clinical experience and the integration of MRI into my diagnostic approach, I recognized that this traditional methodology overlooks critical pathologies and is often fundamentally flawed. Through the analysis of 5 consecutive cases of medial knee pain that I encountered over just 2 days, I noticed a pattern that underscores the frequency and importance of these overlooked pathologies. So, through this study, I hope these cases will change you, that these conditions are not rare and require more attention in clinical practice. I will present 1 out of 5 cases to erase your previous diagnostic category and reset your brain. Unexplained intractable medial knee pain in an elderly patient after repeated intra-articular hyaluronic acid injection. The patient is a 69-year-old female who complained of left knee pain. The patient works at a local grinding mill, performs light daily activities, and looks younger and stronger for her age. However, she walked into the consulting room with a noticeable limp. The limping is a clinically significant point. The patient had planned a trip to Japan and wanted to improve her knee condition before traveling. She visited a local orthopedic clinic and received 3 intra-articular hyaluronic acid injections. A few days after the last injection, she experienced severe pain and began limping. Those who administer injections may find themselves extremely perplexed in such a situation. So, she visited several local clinics, but all doctors concluded that the cause of her knee pain was unknown. When I heard her history, my primary concern was the possibility of secondary infection following intra-articular injection and insufficiency fracture. This necessitated laboratory tests to rule out infection. The X-ray findings were normal. The coronal T2 weighted fat saturation image shows an early stage of posterior root tear of the medial meniscus, subtle high signal intensity in the medial tibial condyle, diffuse high signal intensity in the medial femoral condyle, diffuse periosteal high signal intensity along the medial femoral condyle. The coronal T2 weighted fat and out-of-phase images show subchondral transverse crescentic low signal intensity along the joint surface. The sagittal T2 weighted 3D image shows a low signal intensity of the crescentic subchondral on the inferior surface of the medial femoral condyle. When she had mild discomfort in the knee and sought pain relief, there was an ongoing process of a subchondral bone marrow lesion with an underlying posterior root tear. During the treatment session, the spontaneous insufficiency fracture was evident. So, current severe medial knee pain comes from the insufficiency fracture of the medial femoral condyle. I will continue to discuss the next case in the practical membership class. If you want to continue watching the video, please join the premium membership on my YouTube channel. I look forward to seeing you in the upcoming videos.